First of all, good afternoon everybody. Thank you ever so much for all coming today. It's an absolutely fabulous turnout, and I'm quite stunned that when Kerry sort of talked to me about this small lunchtime seminar thing that we do, and the turnout today is just wonderful. So thanks ever so much for coming, and it's great to see you here at LJMU. I had initially intended to start by asking people in the room to introduce themselves, but I think given the number of people, we'll perhaps skip that bit. But perhaps just to show of hands, who's sort of from the academic perspective and those from practice perspective, just to give me an idea of sort of attendance. So those in sort of the academic side of things, okay, and those from sort of practice, and so it's about 50-50, isn't it? It just gives me an idea for who I'm talking to, really. As Kerry said, my name's Kate Herod. I'm a PhD student here at LJMU. And my previous life was working as a project manager, working with young carers. For those of you who aren't familiar with the sort of young carers service, it's working with young people who care for their parents, either affected by physical disability, mental ill health, substance misuse or domestic violence. So really my passion for the research area came very much from delivering on the front line and the frustrations of delivering a service that perhaps wasn't always meeting the needs that the young people had. So that's where I've come from, really. Today, really, is going to talk about a piece of research that we've just completed in a partnership with LJMU and NSPCC. And it came from the NSPCC, and I'll talk a little bit more about their work, who had a practice-based observation, who noticed something in their practice that was frustrating them, didn't make sense to them, and approached LJMU and requested that some research be done into this area of practice. And we're now 12 months in to this partnership, and hoping to take it forward for the next 3 years. And I think for me, that's the best way for research to come about, instead of an academic sort of pontificating about wouldn't that be interesting, to actually come from a service need, I think is a really sound basis for research to come from. And I think for me, it's a particularly well-chosen topic. So, today, what I'm hoping to do is to talk to you for about 40 minutes, and no more, because I can't stand the sound of my own voice for much longer than that. So talk to you for about 40 minutes, and then we'll have a comfort break to grab a coffee. And then this is a seminar, not a lecture, so I was hoping we could do some group work, looking at some of the themes we've looked at today, and get your feedback on some of the things I'm hoping to present to you, and get some feedback from you, really. So that's what I'm hoping to do. Just the main things I am going to talk about are domestic violence, substance misuse and childhood, and I've really honed in on the childhood aspect from the bigger research project. I'm really focusing on the children and young people's aspect, and I hope that suits what you were kind of looking for today. And a clarification, because I got slaughtered last time I didn't point this out. Substance misuse, I do mean problematic use of substances in this context. So to put that as a baseline, I don't mean the odd spliff on a Friday night. I mean problematic, chaotic substance misuse. Okay. I'm going to start with some really heavy statistics, and I apologise for that. But why are these topics so important to our work with children and young people? The Department of Health estimate that 750,000 children witness domestic violence every year. It's a guess. It's our best guesstimate, because as we all know, domestic violence is one of those issues that is surrounded by stigma, and collecting data on these issues is incredibly difficult. And 90% of children are in the same or the next room when violence occurs. Myth number one, children aren't affected by domestic violence if they don't directly see it. They do, they hear it, and it does impact on their development, and we'll come on a little bit more later to how that affects their development. But I think for me that's quite a striking statistic, and one that we ought to bear in mind with our work with children and young people. UNICEF have it slightly higher. They say it's 1 million children affected by domestic violence every year, and it costs us £23 billion every year, domestic violence in direct and indirect costs, and that's hospital care, that's statutory services, various things, but £23 billion a year. This is no small problem. Drugs, and I am separating drugs from alcohol, which I bracket under substances. We estimate there are about a quarter of a million children of problem drug users in the UK. That's huge. You know, that's a really large percentage of our young people. And research varies, but we think we've only probably picked up about 5 to 7% of those in services. We're not picking them up necessarily, we're not identifying them, and part of my rant today is going to be about how we pick up children who are affected by domestic violence and substance misuse and support them better. Substance misuse costs us about £15.4 billion every year in direct and indirect costs. So again, you know, and that's the hard financial costs, let alone the societal costs really. And alcohol, 1.3 million affected by parental alcohol problems. You know, I'm just giving you an idea of the scale of this sort of thing that we're dealing with really. And then we take it on to and what? What do we mean by affected? This is Children in England with a Care Plan in 2007. And for those of us who are still in practice, Children with a Care Plan used to be the Child Protection Register and has changed its labelling. And 45% of children are registered under neglect and 25% for emotional abuse. And if you look through the care plans, the vast majority of these two categories are down to domestic violence, substance misuse, and or parental mental health problems. So all those children who are under the care of the statutory, you know, the local authority, a huge, well that's well over half, heading up for 3/4 of them, is down to substance misuse and or domestic violence. And I really think that, you know, these are our most vulnerable young people. You know, these are the young people who will end up on the front of newspapers. And I'm going to go on, and I'm sorry to hit you with all the dark stuff, but I thought we'd get that out of the way. 47% of serious case reviews, so serious case reviews for those of us, just as a refresher, of children who have had a review undertaken as a result of a child death or significant harm. 47% are under a year old and 26% are over 11. So I think the first thing to note from that is the type of services that are going to be picking these young people up. Health being a classic one, midwives, health visitors are the best placed people to pick up these young people. And those of us in youth work services will not necessarily pick them up till they get that little bit older. So I think that's a lesson for us all. So 50% of serious case reviews featured domestic violence, parental mental health problems or substance misuse, and often all three coexisted. And I think for me, you know, 50% of the 161 child deaths in England were as a result of the issues we're talking about today. Domestic violence is in over 2/3 of the cases, and 34% had all three issues. And neglect was evident in nearly half of all cases. So I think for me, really, this is the bottom line. This is what we're dealing with. So let's move forward. Just before I do, this is why the NSPCC in Liverpool have designed their services as they have. The NSPCC have three core services, and we all know them: the National Society for the Prevention of Cruelty to Children, with their core mission of ending cruelty to children, full stop. And they've designed their three core services to be, number one, safeguarding. So they're involved in the local safeguarding board, and Alex chairs the local safeguarding board, who's the NSPCC chief exec. But their two other core services is a domestic violence service and a substance misuse service. That's what they do. They recognise that they are the most at-risk young people, and as such have tailored their services to meet that need. And I think for me that says quite a lot. Okay, a really, really brief review of some of the literature. John Devaney has done a lot of work on substance misuse and domestic violence in a child protection context. And he basically gives it to us as blunt and as categorically as it comes. These children have the worst outcomes in Britain, is his, you know, big flag that he sort of waves all the time. These are the children that will have low attainment, are at risk of being runaway children. All of those at-risk labels that we put on young people. He says that domestic violence and substance misuse are the biggies. Richard Velleman's done some work on both substance misuse and domestic violence, and he says that they're both very similar in the actual outcomes for the young people, in that they will both lead to inconsistency in parenting, neglectful parenting, and poor role models. So I think for me that's quite a nice way of saying, well, what does it actually mean? You've got all these statistics about serious case reviews, but what does it mean for the children on an everyday basis? And that's what it means, inconsistency and neglectfulness. I've already touched on that, so some of the work with Jim McVeigh talks about 90% of all cases of DV, children are in the same or adjacent room. And I love this quote. It says, children are perceived as the innocent bystanders. And I think they are. I think if we've got a domestic violence case, they are seen as innocent bystander being the operative word, really, and not as victims in their own right, really. And Paul has done some work talking about how the two are linked again, saying that if children experience domestic violence as a child, later in life, in adulthood, they will go on to use substances to deal with the effects of what they've seen and what they've witnessed, which gives it the sort of long-term and short-term angle. Yes, there's the short-term consequences for the initial child development, but in the long term, there is a higher risk of substance misuse. So it's not just a here and now issue. So what do we do? What do we do already to meet these children's needs? I think the first thing to say is that this is covered legislatively. I'll get that word out. Under the Children's Act 2002, it's as direct as legislation's ever going to be. Impairment suffered from seeing or hearing the ill treatment of another covers the domestic violence sort of thing. So a child is covered under the Children's Act. That is a legislative requirement, that they are impaired by suffering from seeing or hearing the ill treatment of another. And that's where our legislative base comes from. And I think for me, what we're doing is fragmentation at the highest possible level. And I think for me, I see it cascading down locally into our services. Alcohol as a phenomenon is generally dealt with under the Department of Health. It's their bag. Domestic violence is usually the third sector. It's usually delivered by charities, refuge charities, or sometimes the Department for the Deputy Prime Minister, who will deal with the refuge housing issues. Substance misuse will sometimes be under the Home Office because of the links with criminality. And as a result, all of our funding streams come from those different departments. And all of those different departments have different ways of approaching service provision, have different outcomes they want from their funding, which will lead to different ways of delivering services. And for me, that's where our service starts to break down at the very highest level, that we're fragmented. And of course, we've got the old chestnut of children and adult services, and there will always be that divide between where does domestic violence sit. Kathy Humphreys has done it, and Sarah Gorin have done a huge amount on this and say that this is our biggest problem, and this is why half of our 161 children who unfortunately died as a result of these issues is because our service provision is so separate, and we deal with substance misuse and domestic violence very, very separately. And I'll come on to show you later that I think the two of them are inextricably linked. And Thomason talks about this no routine screening. We don't in our services routinely screen for issues outside of our remit. So if we're running a domestic violence service, do we routinely screen for substance misuse and vice versa? And an example of that is that treatment agencies, and I'm talking about drug treatment agencies, very rarely, and I know Liverpool are better than some areas, have child facilities. And I think that some of the research I've done suggests that actually parents wouldn't go in with their children because of the fear of we're going to whip their children into care if they admit to having a drug problem and seek treatment, and they'll be taken into the care of the local authority. And of course, a big thing in our service provision is if we do take on care proceedings for children affected by these issues, the state is preferring kinship placement. And I personally have some very big questions over the suitability of that. But that's probably a bigger debate for another day. So that's what we're doing at the moment. The research that we've undertaken here at LJMU with NSPCC in the last year really tackled things in this way, and this is a very basic model. that shows we looked at substance misuse and domestic violence very, very deliberately overlapping, and we were particularly interested in this sort of overlap in the middle. But we also wanted to look at how those behaviours pass through the generations and how these behaviours are passing from adult parents to childhood and then being cascaded through and just becoming a problem that we can never quite stamp out. Why did we do that? I said to you that I would share with you why these two issues are so closely linked, and I think these statistics sort of prove it, really. A study in Sweden, 49 women in alcohol treatment agencies, 65% have been beaten in a domestic situation at least once. In the USA, 360 women in substance misuse agencies, 60% were currently or had experienced domestic violence. In the UK, 60 women who were using crack cocaine, 50% needed hospital treatment in the last year as a result of partner violence. That's heavy-end domestic violence. Needing hospital treatment is, well, it's a scary statistic, really. In England and Wales, 50%, and the World Health Organization says that 50% of interpersonal violence victims reported the perpetrator had been under the influence of alcohol at the time of assault. And I think that those in practice will recognise that as something that from a domestic violence service provision, that alcohol is a feature of their work on a daily basis. But what are we doing about that? Are we picking up on it and are we running forward? So what we did was we carried out semi-structured interviews and we did both professional and personal stakeholders, and we tried to do this sort of holistic analysis. And in a professional capacity, I've interviewed NSPCC practitioners, refuge workers, social workers, service managers, police officers. You know, the list goes on and on. And in a people affected with these issues personally, I've interviewed domestic violence victims, perpetrators, and individuals with substance misuse problems who are parents and non-parents. And you know, the results of those we transcribed and analysed, and we did some thematic analysis. And what I wanted to do today was just share some of the findings, and I've picked out some that are perhaps more relevant to our work with children and young people, and discuss some of them with you. And I think to make some general observations, I don't know if any of you will be surprised as I was, that people were generally more open to talking about domestic violence than substance misuse. And I've battled with myself whether this is a cyclical thing. Maybe it's just that it's a hot topic this month, and maybe if I'd interviewed them a month later. But trying to get generic practitioners to talk about substance misuse was a nightmare, absolute nightmare. And it was almost sort of a, well, I wouldn't know about that. You know, drugs is a scary thing. I don't understand the difference between an amphetamine and and it was just a no-go area, really. Practitioners wouldn't talk outside their own area of practice. And for me, that goes against everything we've learned in Victoria Climbier and Lord Laming's work and Every Child Matters. We're supposed to be joined up working, and yes, specialists, but practitioners showed a general lack of ability and or desire to talk outside their own area. They were a domestic violence worker, they were not going to talk about substance misuse, and vice versa. And nobody at all would talk about mental health. That was an absolute, we don't talk about that at all. Difficulty to engage with service users in the research process. I'm sure none of us are surprised at that, and particularly men. And again, I don't think we'll be surprised that it was difficult to interview male service users. But I think my point today is why are we allowing this? Why are we accepting it? And I'm going to talk a little bit more about that later on. And where deprivation was also a factor, poor outcomes were more apparent. And I guess this manifested itself in, a good example is victims of domestic violence. If they don't have the financial resources to pay for a hotel very quickly, will end up in a women's refuge. And outcomes may be poorer than perhaps if they have the financial means to get through a crisis period. and if they have their family who can support them through an initial crisis, the outcomes are generally much better than those who don't have those financial reserves. And substance misuse, life becomes much more chaotic if you don't have the finances to back it up. And I think we all know that, but I guess it's reiterating the fact that these are our most at-risk young people. And if we've got deprivation as well, the story becomes a lot bleaker a lot more quickly. So just some general observations. Going into the sort of specific findings. Whether it was domestic violence or substance misuse didn't appear to make a difference to the fact that attachments in the family broke down. There was lots and lots of stories of mums who didn't have good attachments with their children. And they themselves describe loveless, in their words, childhoods. They didn't have a good bond with their mum and dad. And this seems to be one of the specific behaviour traits that's passed through the generations. And I think what I found in services was that social workers would regularly say, poor attachment with mum, poor attachment with child. And I'd say, and what was the resulting follow-up? Well, nothing. We just have to put that in the document. We have to put that in the court report. They have poor attachments, right? So it's a tick box. They've made a diagnosis that it's a poor attachment. That's that dealt with. Kind of let's move on, shall we? So I guess that's something for us all to think about. Family. I touched on earlier about the suitability of kinship placements. Overwhelmingly, and I don't want to start creating stereotypes, but I definitely found a theme that these problems didn't happen in isolation. There was a feeling of the apple not falling far from the tree, that, you know, mum was like this, I had a childhood like this, my auntie's like this, my auntie's been battered. So this sort of kinship placements of, you may, for example, get alcoholic grandparents looking after their grandchildren whose parents are alcoholic, was a really common theme. And I guess for me that's where I start to question kinship placements, that we're removing children from their parents and placing them in kinship care, but perhaps with these two issues that's not necessarily the right thing, especially as we all know that the huge lack of support that grandparents are given if they do take on the caring role, as an example. Another theme that came out of the literature very strongly was the co-occurrence of mental health problems with both of these issues. And mental health was very rarely stated as there is mental health problems here. It was emotional problems, or they're not quite coping. You know, this one to me, his emotional problems, and he'll threaten to kill himself as a means of control, and he smeared his slash wrists all over the door. And this is not classified as a mental health problem. He was having some problems coping. And it sort of surprised me that I thought, I suppose in my naivety, that we were sort of light years on from that really. But the practice out there is still mental health is not an accepted phenomenon. And perhaps it ought to be. Though I have spoken to some colleagues at the NSPCC who tell me the reason that we don't dress it as mental health problems anymore is that in Liverpool there's nowhere to refer on to as a professional, so why would we bother? Okay, pregnancy. This is the biggest risk factor that I could see as a common risk factor. The number of women who report the first incident during pregnancy is growing. This is particularly of domestic violence. So women who report the first incident, or the domestic violence escalates during pregnancy. And I think for me, alarm bells of children we already consider at risk of domestic violence or substance misuse should start ringing really, really loudly during pregnancy. If there are previous reports of miscarriage, stillbirth, that's another risk factor that we really ought to be taking into account. Coping is another subject that links domestic violence and substance misuse. And for me, it's a behaviour that is passed from parents to children. This is where, as professionals working with children and young people, we really can pick up on it. The way parents cope with domestic violence and or substance misuse. It seems to be a relationship between the two. For example, people will drink to medicate the effects of domestic violence, but it's a chicken and egg. Which one came first? We'll never know. From being a strong person, I ended up weaker and weaker, applicable for substance misuse and domestic violence. I've known a woman who killed herself, who took an overdose. Domestic violence, substance misuse. Substances are some sort of crutch, as I've just said, using substances to medicate the effects of domestic violence, or the substances increase the likelihood of a domestic violence incident. And I don't think we'll ever be able to get to the bottom of that. And perhaps we shouldn't. Perhaps this isn't a single causal relationship, and it is a complex web of different issues. Okay. It wasn't a childhood, really. It's a bit complicated. This was, for me, the biggest thing I took away from the research. These issues just steal childhoods. For me, they were characterised by lots of house moves, lots of travelling around, lots of ducking and diving when the door was ringing, lots of time at the police station, lots of time I stayed with this auntie or this friend. And childhood is just gone. The right to play, as we all know, is out the window and not to be seen. And that's true for both of the issues. And I suppose for me, this was the biggest surprise in the research, and one that I've put down as a theme for us to discuss later on. When I was interviewing, I found this quite unexpected sexism, and I hate to use that word, but sexism in our services. Women, I'll use a straightforward example, who are using drugs, mums who are using substances and were in receipt of services, were doing it because they'd had poor childhoods, they'd had low self-esteem, they were using it to medicate the effects of problems they'd had. And practitioners would always explain their behaviour with quite logical, reasonable explanations. Men, who were dads who were using substances, were evil, the devil incarnate, had made a deliberate choice to do what they do, did it to annoy mum, and they were perceived in a very, very different way to the way mums were and the way women were. And I think for practitioners, when you're working day in, day out with men who perpetrate violence, that's very difficult to maintain a positive stereotype of them. But for me, the way men were treated and the way they were perceived by practitioners was quite startling. And I wondered if there was any weight in the sort of mirroring or self-fulfilling prophecy, labelling, kind of taking forward the way men interact with services. And this bottom quote of, I felt like a mushroom kept in the dark and fed shit, was kind of the way men generally perceived their service provision. Abusive men are very clever at sussing out the vulnerability of women, was generally the way men were perceived in both sets of services. And I just wonder why we've got this different perception and why we treat men and women differently in those services. Okay, so I'm about on time where I wanted to be. Service provision. We talked a lot about what we're doing to meet these needs, and I think the biggest sector that came out as the poorest performers in these areas is the judicial system. And the consensus was that the abuse in domestic violence particularly carries on through the legal system, and that men and dads, fathers, will use the legal system as a weapon of domestic violence, and they will use it to control women. If you don't, I will take this to social services. And it was used very much as a controlling sort of force, really. And again, I've already said that for a lot of people, substances was a dirty word. Well, there's a bit of, you know, coke, but that had no impact on the domestic violence situation. He's a very laid-back dad who doesn't really get involved much, and he probably does need to be more motivated in regards to his parenting. He does smoke cannabis, but that's not relevant at this point. So it's, there's definitely an inequality in the way services view substances, which perhaps we need to take forward. So, recommendations from the research and recommendations for our practice, which I'm hoping we can discuss after our break. At the sort of highest level, I started by talking about the fact that we're not dealing with these issues together, although perhaps we should be, because they're fragmented at the very highest level. And if our funding streams and our objectives and our service provision is fragmented at the highest level, then that needs to be fixed before we on the ground can do anything about it. Avoid over-conceptualising, and the classic example was when I talked about attachments. Oh, there was a poor attachment, or there was a bad attachment. And this trying to tick the box and bring everything down to a very low level is not doing our service provision any good at all, and it's not meeting the needs of children and young people by trying to label everything and put it into a box. The old chestnut of caseloads, we cannot meet the needs of children and young people while statutory social workers have caseloads of 50 plus. It's never going to happen. And in the third sector, things can be just as bad. Funding and capacity, it's something that I think has to remain on our agenda until we win the war, really. But until services are stable and given longer term contracts, we can't begin to develop our services to meet the needs. Stop the blame syndrome, and I think for me Baby P was just a classic example of this, where the first thing we looked for was a hunt of which social worker we need to fire and who in Haringey Council needs to be got rid of. And that means that social workers end up, and in the third sector, spending more time writing reports and trying to write everything down that they've done, because they're so worried about taking the rap if something goes wrong, than actually delivering a high quality service. Routine screening is the biggest message that I hope we take away from today. And the knowledge to screen. If we're working in a specialised service, that's great, but we need to be screening outside our own area of expertise. And it's not happening, is the message. And recognise the harm, that it doesn't have to be physical. A child doesn't have to be physically injured for there to be harm present in its life. And I thought that message was out there in the wider arena, and it's not. And I think we need to keep hammering that back, and to think outside our own fields and know who to call and have the referral forms for the other agencies. And that really is the main recommendations.